I think we should get started, Maria.
Yeah, fine. Hello, everyone. Is the sound okay?
You can go ahead. We can hear you.
You can hear me. Thank you. Good afternoon, everyone. It's afternoon here in Denmark, at least. And thank you so much to everyone for joining us for this online presentation of the report, Prescription for Change. It's an honor for me to welcome you all. The report is a major work that has been made in collaboration between Systemic, Eunomia, and Healthcare Without Harm. And it is a first of its kin of a report in a size like this, in a matter of this, trying to approach plastic consumption in healthcare from a systemic perspective. My name is Maria Gaden. I am Chief of Development at Center for Sustainable Hospitals in Denmark. I'm also a member of the European Board of Directors at Healthcare Without Harm Europe, and a member of Green Transition Denmark, which is a national council here in Denmark. Now, I am thrilled to be welcoming you all here and thrilled that we have received a report like this, because plastic consumption in healthcare is definitely an issue that needs to be addressed, not just with attention, but with action. The amounts of plastic used in healthcare today globally are almost impossible to imagine. We're talking millions of tons. We have more and more data, and this report supplies us with even more. But basically, all you need to do is to imagine the last time you went to a hospital and underwent some kind of surgery or treatment, or imagine the recordings you've seen of such scenarios, and then try to zoom out and imagine a whole hospital where this is happening in every room to some degree, and then imagining it happening in every hospital in just the region where you're living in, hour after hour, and then imagining the country, the part of the world that you're living in, and then trying to zoom out and imagine how much plastic is going through all of these systems hour by hour, day by day. And on top of that, the demands of treatment globally are rising due to the elderly population, the more complex diseases that we are able to treat, and due to the fact that big regions of the world are right now expanding the healthcare system, which is wonderful, because more health and more treatment for more people is, of course, a global goal. But if they do expand the way of treating patients and do it in a way that we are doing it in the more developed part and more high-income countries of the world, the amount of plastic consumed in healthcare will be rising quite significantly during the next years. As it is today, we are well aware that climate change are the biggest threat to health globally. We are also well aware that healthcare are contributing to this, or healthcare activities are contributing to this CO2 emission and thereby the climate change, which is kind of a paradox, since we are supposed to create health for people, but right now we are contributing to the climate health that are threatening health globally. On a global scale, the average CO2 emission from healthcare is about 4% of the global emissions. In a country like Denmark, where I live, it's about 6% of the national emissions that are coming from healthcare. In countries like India, it's like 1.5% due to the estimates that we have. So what we can see is this difference between the high-income countries and middle and low-income countries, where the more developed and the more complex and higher amount of treatments that we are offering in the country, the higher our emissions are, which is naturally. But that also underlines the importance of changing the way we are consuming in healthcare. We need to move away from a linear consumption of single-use products to a more circular consumption. And doing this is not just about CO2. A sustainable healthcare system is about more than lowering the CO2. It is about choosing wisely. It's about using products that are free of damaging and toxic chemicals all through the life cycle of the products. It's about considering the social sustainability all through the life chain of the products, from the production line through the waste handling line to the waste handling line. There are 9 planetary boundaries, and looking at a sustainable healthcare system means looking through all of the lenses of these planetary boundaries. It means looking at this in a global systemic perspective. How do we create health in a way that does not contribute to lowering the life value or life quality for anyone, anywhere at this planet? So where do we start and how do we do this? Many people are already working within this area, trying to make the transition from where they stand. So much has happened in the last 5 years on a global scale. That's wonderful, and it gives me hope. But this report helps us even more by mapping out the 7 high-volume plastic products, by mapping out 7 barriers that needs to be addressed. And I think also indirectly, this report underlines the fact that changing healthcare's consumption of plastic into a more circular, more sustainable pattern is not just a business of the hospitals or the healthcare facilities. It's not just a business of the industry either. And it's not just a business of the waste handling people. And it is not just a business of the politicians as well. It is a business that matters to all of us, and it's a business that needs all of us to take action in a different way than we are doing today. So I am very much looking forward for the report to be presented more details. And I'm looking forward to a panel discussion where we will dive into some of the barriers and possibilities within this area. And I am thrilled to know that so many people have chosen to spend their time with us today. So a warm welcome to you all. And then I will pass on the mic to you, Joni Shiran.
Thank you so much, Maria, for those opening remarks. And thank you to all of you for joining us today and taking time off your busy calendars to join the webinar. My name is Joni Shiran. I'm a partner at Systemic. For those who don't know Systemic, we are a B corporation whose mission it is to work on the system changes needed to achieve the UN Sustainable Development Goals and the Paris Climate Agreement, with a particular focus on the circular economy. We've done this work together with Eunomia, who are also a mission-driven organization with a similar mission, and my colleague Pallavi will introduce herself and Eunomia later today. Why did we tackle single-use plastics in healthcare in the study? The main reason is that single-use plastics in healthcare are often excluded from most of the conversations around circularity, around decarbonization, and other similar conversations because of the sensitivity of the sector. But we think that it's incredibly important that healthcare is included in this conversation. You know, there's evidence that in many regulations, such as packaging and packaging waste regulations, PPWR in Europe, and many others like it, also in other regions, are excluding or largely excluding healthcare. Even many of the activist NGOs who are asking for ambitious action on plastic, some of them exclude healthcare because of the sensitivity. But the reality is that healthcare is one of the most plastic-dependent sectors in our economy, where the very large number of plastics being used, which we'll show in a second, it is growing very quickly. And without action, the amount of virgin plastic, the amount of plastic waste, the amount of greenhouse gases, but also the costs that are associated with those things, all of those are on the rise. And the other reality is that solutions do exist for this challenge without compromising, of course, on patient health. So it's not for nothing that Healthcare Without Harm recently published an open letter asking for plastics to be included in the conversation in things like the Global Plastic Treaty and in other related policy discussions. And 48 million healthcare professionals from around the world have signed this open letter asking for the healthcare industry to be included. So that is a bit the framing of the report and why we went into it. Before I go into the actual report findings, I want to thank our distinguished expert panel who helped us throughout the report by providing from their experience, from their insights, from their knowledge, making sure the methodology and the approach is accurate. We have Professor Mahmoud Bouta from Brighton Sussex Medical School. We have Jason Fisher from the Houston Methodist, Leanne Hogg who's head of waste and resources at the NHS, Dr. Nicole Huntfield, an associate professor from the Erasmus University Medical Center, and Rachel Meadle from the Baker Institute for Public Policy in Houston. Today, in the panel that we have today, after my remarks, you will hear from Professor Mahmoud and a few other panelists. So stay tuned for that. So with no further ado, I think the report really tries to answer four main questions, which I will take you through today. The first one is, where are we headed under a business as usual scenario, kind of if no meaningful action is taken? The second is, what are the practical solutions that exist, and what are their economic, environmental, and social implications? Number three is, what is blocking progress? And number four is, what will it take to drive real system change for single-use plastics in the healthcare sector? So first and foremost, where are we headed? In short, not a great place, right? So we focused on, you see here on the screen, the 7 product categories that make up the vast majority of single-use plastic consumption in the healthcare system, right? So it's fluid bags and tubing, gloves, rigid devices, device packaging, PPE, which obviously have had a massive surge during COVID, but a lot of those high numbers still remain, not as high as COVID, but definitely much higher than before COVID, and also wipes and pharmaceutical packaging. So these are the 7 categories that we focused in, and the scope of our work was Europe, so EU 27 plus the UK, and North America as well. And in terms of where we headed, we see that today we have 2.1 million tons of single-use plastic being used across these 7 categories in these geographies, which equates to 9.3 million tons of CO2 emissions, mostly from the production of these materials, but also from the incineration, particularly in Europe, and other emissions during across the life cycle. And from a total system cost perspective, we're talking about $56 billion that is being spent every year, mostly by taxpayer money, of course, in an environment where fiscal budgets are very, very tight as they are. So that is the current situation of single-use plastics in Europe and North America. And based on our modeling, we estimate that under a business as usual scenario, these numbers are expected to get worse. So plastic waste is expected to increase to 2.9 million tons by 2040. Greenhouse gas emissions will also have an increase to 12.9 million, and the costs are also increasing. All of these costs in the 35 to 40% growth relative to today by 2040. So this is not a great scenario, not one that I think anybody wants to see. So what are the practical solutions that we can address, and what are their implications? And the good news is that there are many solutions, circular solutions, that have been proven and can be deployed. Obviously technical solutions, but also that do not jeopardize in any way patient safety, which of course is a top priority for the sector. And we essentially grouped solutions across 5 main buckets. As you can see there, starting at 12 o'clock and kind of going clockwise, refuse, rethink, reduce is a major solution category. There's many solutions and many, a lot of potential to reduce the amount of plastic going in the system. Secondly is reuse. So what are the applications that we can shift to be reusable, such as reusable gowns and metal trays and other examples of things that can be reused many times. Substitution to other materials where it makes sense. Improving recycling is very important. Recycling today in the sector is essentially close to zero. Especially in Europe, the vast majority of plastics end up getting incinerated, even the non-hazardous ones, even the non-toxic ones. Almost all the waste in the sector goes straight to incineration. We think that with the right measures in place, with the right infrastructure in place, some of the plastics could be designed for recycling and then actually recycled in practice. And then last but not least, procuring low-cost greenhouse gas emission plastics, which do already exist and can already perform at the required specs. So these are the 5 categories. If we implemented all these 5 categories of levers at scale across Europe and North America, across hospitals, we think we could achieve a 53% reduction of total volume of single-use plastic by 2040. So from 2.9 million tons to less than 1.4 million tons. You can see the split there between the different categories and the different levers. But essentially, many of the upstream solutions, such as the reduction ones and also reuse, are a big part of the opportunity. And applications such as gloves are also big, also the others, but gloves is probably the category with the biggest potential for reduction. So this is what it could look like. This is the size of the opportunity. Just to bring these numbers a bit to life and what would it actually look like. I'm going to show 2 case studies. Of course, in the report, we show many, many others, but these are actual hospitals who are actually implementing some of these solutions. The first case study is from the Manchester University Foundation Trust, obviously part of the NHS system here in the UK, where emergency drugs were used or were stored in operating theaters just in case there's an emergency in the operation and these drugs are needed. Essentially, the drugs, when the emergency drugs were not needed, the syringes were disposed, including the drugs that were in them, and that was gone to waste. And actually, what they've done back in 2023 is to shift to pre-filled syringes that actually can, if they are not used, they do not have to be disposed of, and they can be stored for future use, saving not just the plastic waste of the syringe itself, but also the chemicals or the substance that are in them. And this saw a reduction of 63% of operating theaters implemented this and reduced their syringe use, which led to an 84% reduction of total syringe waste in the hospital and an 86% reduction of associated greenhouse gas emissions. Now, just imagine what would happen if we implemented kind of this kind of lever across the entire NHS system, across all of Europe, and maybe globally. What would be the saving potential? Again, with no impact to patient safety, of course. The second case study is from France, from the Clermont-Ferrand University Hospital, where they had 10,000 single-use foam swabs that were used annually, and essentially in a recent intervention, they replaced single-use sets by reusable forceps and reusable metal cups, which saw a reduction of 450 kilograms of this waste, and also bringing significant cost savings. In this case, just for this intervention, saving about 15,000 euros per year, which was a very high ROI relative to the initial investment, and also saved a lot of space and logistical complexity in the hospital. So again, just imagine if we scaled this solution across France and across Europe, across all hospitals. Like these, there's countless case studies that we've come across. In the interest of time today, we're not going to go through all of them, but in the report, we spell out many more case studies, not just from Europe and North America, but also from around the world. And I'm sure you guys are familiar with more examples as well. So I think the main message here is that the technical solutions do exist. It's just a question of how do we make sure we have the right regulatory frameworks, the right incentive systems, and the right investments to make it happen. If we were to scale these solutions, the 5 levers that we're talking about at scale, in addition to the reduction of single-use plastic that I showed before, we would also see a reduction of 55% in greenhouse gas emissions from 12.9 million tons of CO2 under BAU to 5.8 million under this ambitious system change scenario. And you can see there the split of the different levers and the impact they would have. Again, of course, the last lever around procuring low greenhouse gas emissions would have a big impact on the greenhouse gas emission numbers. And from a cost perspective, which of course is something that governments and leaders of the healthcare system are very mindful of, there would also be a significant reduction of cost, mainly driven by reduction of overall all the waste, like the examples of the syringe that was wasted before it was even used that we saw earlier. All that is also cost. So even if after accounting for the increased cost of low greenhouse gas emission plastics, we're still talking about a net reduction of 24% in costs in the scenario. So to summarize, in terms of the size of the opportunity across Europe and North America, we think that under a high ambition scenario, we could have 1.4 million tons of single-use plastics which is more than a 50% reduction, 5.8 million tons of CO2, which is more than 50% reduction, and $58 billion of costs, which is a 24% reduction. And to putting these numbers in perspective, one against the other, you can see how today compares with BAU, compares with high ambition scenario. I think we all agree that the high ambition scenario is one that we would want to aim for, because across all these three KPIs, it shows superior results. So the main question becomes, if this scenario is so great from these three perspectives, single-use plastic, greenhouse gases, and costs, why is it so difficult? What is blocking progress? And that was the next part of our analysis. And we spoke with dozens of experts and practitioners from the system, and we essentially mapped 7 main barriers to circularity, which I'll briefly talk you through, and I think we'll hear from our panel later today more about these in more detail. But essentially, one, there's a fragmentation and siloed governance. So these are obviously very common, but many times decisions are made in a siloed way. Sometimes hospitals, have different departments dealing with different things, and it's not very, and decisions are basically not taken from a system-wide perspective. So that is one of the barriers. Data gaps, as you wouldn't be surprised to hear, and lack of transparency are also a big challenge. Oftentimes hospitals don't have exact data for what they're procuring, what is the recyclability of that plastic, what are the greenhouse gas implications, what is the material composition, let alone recycling rates and things like that. So there's a real work to be done around more data, but also more transparency, because even when data does exist, oftentimes it's a proprietary data and it's not shared widely. Thirdly, short-term costs are sometimes optimized over life cycle value. In the example of the syringes I gave you earlier from Manchester, as it turns out, the single-use syringes are cheaper when you buy them compared to the pre-filled ones. But if you take a life cycle perspective and account for all the waste that has gone into the system and all the other costs, then actually the pre-filled was a significant cost saving, as you saw in that example. So by taking a full total cost of ownership and not just the procurement cost, that can also unlock a lot of potential. Regulatory challenges, as I mentioned in my opening remarks, as did Maria, PPWR and other regulations exclude to some extent, or to a large extent, healthcare sector, and so that is not helping circularity. There's infrastructure gaps. So even when some materials are recyclable, in practice, sometimes we don't have the segregated collection that is needed, the collection infrastructure in the hospitals and the entire supply chain to make sure that materials actually get recycled, which is why the vast majority of plastics in Europe go to incineration, which takes us to number 6, because even in hospitals that do have segregated collection, and we have visited a hospital doing this work, which actually had separate collection for different types of materials, the reality is that oftentimes the staff are not trained or are not incentivized to put the right things in the right bin, and everything gets sent to incineration. And then also there's lastly market failures and demand signals. So we think there's kind of barriers all across the system, and therefore there's not a single silver bullet solution. We really need to think about comprehensive system-wide solutions, and we do need all stakeholders to work together to achieve this change. Which brings me to the last question that I'll take you through today, which is, what will it take for system change? So taking into account all these barriers, how do we actually make change happen at scale? And essentially, I think the key for this, again, as you won't be surprised to hear, is collaboration, because all stakeholders have a role. Of course, policymakers, of course, healthcare leaders, pharma companies, hospitals, waste management, all stakeholders need to work together in these solutions. We've put together this simple framework that talks about how we can overcome these barriers and achieve system change. And essentially, we've identified 4 main buckets. The first one is around creating an enabling environment. So making sure the conditions are in place to make the right choices also be the easy choices and the cost-effective choices. The second is around establishing multi-stakeholder transformation bodies to actually enable and implement the transition. The third is around delivering transformation projects to show that it can be done at scale. And of course, we need to make sure we have finance. which is the fourth bucket. Let me take you through each of these. So enabling environment, this is mostly around policy change and making sure that policies are creating the right incentives for circularity and for decarbonization, but it's also around behavior change and making sure that healthcare professionals have the tools they need to implement the changes that we're talking about. When we look at transformation bodies, then of course we need to set up the right data systems to make sure that hospitals and other players in the system have the right data they need to make the right decisions. We need to, of course, set targets for the sector and work on develop partnerships and projects to implement and to co-invest in these solutions. Thirdly is transformation projects. So here we're talking both about circularity projects, including many of the examples that I gave before in the case studies. So how do we, implement more of these projects and scale more of these projects, but also include the procurement of low greenhouse gas emission plastics. And last, but certainly not least, we need to ensure finance. We do think the ROI here, even from a purely economic perspective, is very, very clear based on the cost savings we showed, but it does require some investment upfront in the short term to unlock some of these benefits in the medium and long term. Specifically, we need funding for infrastructure where that does not exist, separated collection, proper recycling streams and so on. Same thing for reuse, but we also need to invest into innovation to make sure that we have, the right solutions at the right cost. So taking all this together, I think the bottom line is we have a lot of work to do. Many stakeholders in the system, or all stakeholders in the system, need to work together. But the good news is that we do have the solutions. We know what it takes. So that was the synthesis of our work. I'll invite you all to read the full report. It's available in our website, in Systemic's website, and Eunomia's website. You can take a look not just at the full report, but also we have a standalone executive summary. We have the full methodology and assumptions detailed out there for those who are interested. And we also have a specific appendix with specific European focus analysis, and as well for North American. And we have a 2-page summary if you want to share with your colleagues or leadership teams. And all of this can be accessed, as I said, in the Systemic and the Eunomia website. With that, I will now pass it over to my colleague, Pallavi Madagakisara from Eunomia. Pallavi, over to you.
Thank you, Yoni. So I'm Pallavi Madagakisara. I'm a managing consultant at Eunomia, where I work at the intersection of policy, innovation, and finance to advance circular economy solutions that reduce waste, carbon, and build resilient systems across numerous sectors, including healthcare. And for those of you that don't know about Eunomia, we are a consultancy focused on accelerating the transition to a circular, decarbonized economy by working with governments, brands, investors, and NGOs to align policy, infrastructure, and innovation. So as we've all just seen from Yoni, business as usual is clearly not an option. And if we don't act and act soon enough, by 2040, everything, including plastic waste, greenhouse gas emissions, as well as costs in healthcare could grow by as much as 40%. So the key questions that Yoni left us there that we are going to delve into with our panel is what's holding back adoption and what enabling conditions will fundamentally accelerate progress. And what does success look like if we did fast forward to 2030 or 2040? I'm absolutely thrilled that we have such a diverse panel today with us, from health policy and clinical leadership to on-the-ground deployment expertise. Before I introduce the panelists, just a quick reminder to our audience that has joined. Please feel free to type in your questions in the Q&A box at any time during the course of this discussion. And as we get questions and where I find the opportunity, I will make sure to pull those in and ask our panelists. So without further ado, our first panelist, in case you missed the opening comments, is Maria Gedden. She's a member of the European Board of Directors at Healthcare Without Harm. She is also the initiator, former leader, and now Chief of Development at Center for Sustainable Hospitals in Central Denmark region and board member at Green Transition Denmark. She's currently doing a public industrial PhD on how to scale and implement qualified, tested Scope 3 carbon reducing interventions in healthcare. Maria's expertise and experience comes from years of clinical experience as a midwife, a diploma in clinical supervision, and an international master's degree in leadership and innovation in complex systems. Our next panelist is Professor Mahmood Bhutta, who is the chair of the ENT surgery at Brighton and Sussex Medical School and director of the Green Healthcare Hub, a national academic centre supporting decarbonisation of the UK national health system. He has a long-standing interest in environmental and labour rights, harms caused by medical supplies. And our final panelist is Guy Wing, who's a contract manager at SharpSmart UK, the leading provider of reusable Sharps containers within the NHS. Through his work with 12 NHS trusts, he supports implementing circular economy solutions and driving carbon reduction initiatives. And within SharpSmart, he has led on the data collection and presentation of the annual carbon reduction plan. Welcome, panelists, and I'm so thrilled that you're joining us today for our discussion. Just to kick us off, while we get questions from the audience, perhaps a good place to start is to think about what's fundamentally, in your view, holding back adoption of circular practices in healthcare. Is it technology, economics, is it culture, or is it actually something else? And maybe I'll start with you, Mood, if that's okay.
Sure. So the question was about what's holding back circular, is that right?
Yeah.
I think the main issue actually is that we're dealing with a very complex system, as Yoni highlighted in his presentation. It's not one single thing. And our research has shown that often when people are trying to transition to making everything reusable, they're working against the system. Quite often it's been led by individuals who are passionate about making things greener, about circularity, and they have to work so hard against a system that is set up to have everything reusable. Business as normal. This is the way we do things. This is how we procure things. Infection control will say, no, you can't do it. So ultimately, I think we need greater leadership. We need institutional leadership, whether that's at individual institutions or a government level. Ideally, we need both, that actually enables large-scale change. So you say this is a standardized way of doing things. This is, for example, infection control, national policy on that, or international policy. We have national or international infrastructures that support a reuse economy, for example, through decontamination and sterilization. And we have international procurement policies. My bugbear is we say we'll always buy a reusable product, whether it's plastic or not, in preference to anything else. That's our policy. And when we create all of that infrastructure, then I think we'll see some change starting to occur.
I'll turn it over to Guy. What are your thoughts on that, Guy?
Yeah, I think Mood summarized it perfectly by saying it's complicated, which is one of the biggest barriers. And I definitely agree that the complexity of the problem means that people will try and solve perhaps an objective with a lower output, and more national expert guidance will help things move forward. One of my biggest bugbears that I've noticed from being on the waste management side is a lot of NHS trusts in the UK have come out with a proud zero to landfill policy, which is a very nice tagline, but in terms of circularity or carbon reductions, doesn't really have much meaning, because it's actually encouraged a culture of single use for incineration. So I think that by the nature of it being a complex problem to solve means that there can be some false narratives or distractions which take away from really robust solutions which are better come from expert leadership. So yeah, I echo that.
Thank you, Guy. And Maria, if you want to chime in on that as well.
Yes, definitely agree with what's been said. And and with the need of not just personal leadership or organizational leadership, but institutional and national leadership on this area, since the systems reach out and are connected globally, basically. And I think one of the things holding us back are, or some of the things are the incitement structures. Because when we look at the financial structures, when we look at, in Denmark, at least the political structures where you are re-elected within a very short period, when we have to report our finances each year and be square and fair about zero for each hospital unit and stuff like that, it's all these kind of structural limitation that surrounds us and that surrounds the leadership on both organizational and institutional level, that sometimes I think makes it hard for anyone to find the courage or to see things in the right perspective in order to make these investments. Because switching from single to multiple use is sometimes a financial investment. It's sometimes a plan that takes years. It's sometimes something that you need to plan like 5-10 years ahead. Sometimes we can just do it now, and we've seen that and we're doing it. It's wonderful. But if you are only elected for like 3 years and you need a 1-year budget, it's hard to make these systemic changes. So the incitement structures, the financial structures, are really part of the systemic change.
Great. So I heard a few things. I think it's complex. So let's try to see if we can tease out a few of those as individual topics in and of themselves. I think between Mood and Guy, you talked a little bit about perhaps false narratives or maybe a lack of an understanding or awareness as an example. So could we maybe jump into that? So the data shows that there is a lack of awareness in healthcare about plastics origins and impacts. And I guess, Maria, you've done quite a bit of these transitional research from industry to academia and back. So how do you build awareness among clinicians, staff, and administrators in a way that resonates with patient safety priorities? Maybe I'll start with Guy on this.
I'd suggest, so yeah, how can we make, the question is, how can we make patients and staff more aware of what are going to be the high impact projects? Well, I think it comes back to national leadership and organizational leadership. Within the NHS, there are definitely some green shoots of things to be positive about. So within ICB structures, which is an organisation of multiple NHS trusts and other third sector organisations, roles in transformation and sustainability are being centralised, which I think is a good thing because there's more regional leadership. So that's something to be positive for. Yeah, that's my insight on that. Mood, I don't know if there's anything that you've seen that you think is an effective lever.
Yes and no. So I think it actually needs different levers for different things. I mean, you've highlighted there that gloves are one of the biggest areas where we could reduce use. We know that around 2/3 of all gloves are inappropriate. It's just behavioural norms that we put on gloves. Gloves didn't exist 50 years ago in healthcare, they existed only for surgeries. But now people put on gloves all the time. That is a complex phenomenon because that's individual behaviour, and trying to change individual behaviour is difficult. And we need to get to a cultural norm where people putting on gloves are seen as the odd ones out, because it's most of the time it's completely unjustified. I mean, I never used to wear gloves. I just wear gloves every now and then when I'm examining inside someone's mouth, and that's it. But I see people putting on gloves to move patients. That's just because of cultural norms. When I speak to people in a non-confrontational way, this is the difficulty. You don't want to confront people. They get defensive. They were less likely to listen to what I say. People just say, why do you put on gloves? Because everybody else does. And that's actually a failure of us to educate staff on why people wear gloves. People are never taught Why you put on gloves? They just learn it by mimicking what other people do. I would say that's actually dangerous to patient care. People think maybe they're magic. Actually, they're covered in bacteria. We know them because they're not sterile gloves. So that's one lever. Other levers depends upon the other things that we're talking about. So could we have a system whereby health systems are accountable for what they do in delivering on green strategy? Some people say, no, 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 health systems are under such terrible strain. And I understand that. But actually, until we give metrics, we usually don't find that change happens. And the rewards are huge. You've already shown the potential huge financial savings. So unless you're working in a health system that believes that we are not in a financial deficit, because certainly our health systems in the UK are in a financial deficit, it's important to do this. And if you believe that we are not in a planetary crisis, it is important to do this. We just have to tell people to do it. This is the way to do it, and we will support you to do it. But if you change those levers and ask institutions to report on it, and then we find that financial savings are there, those sort of larger scale changes to what we're buying in the first place can also come about.
And Maria, based on your work in Denmark, are there procurement or policy levers that you think could be scaled across Europe to accelerate the shift away from single-use plastics or problematic plastics in healthcare?
Yes, there are, but it's complex. Just to rephrase again, I think just to comment on what's been said, individual change is definitely part of this systemic change. We cannot reach this goal or the potential without addressing this and trying to work with it directly. And one of the things that we try to balance is how do we educate and tell everyone about what's right. The glove could be a good example. And spend a lot of time on talking into the resistance and the not knowingness that is within our organization, versus spending our time on those who are ready to run and using them as an example, so we kind of can show and not just tell. Say, hey, they did it over here and they did that and they did this in the NHS, by the way. That's also a good story. So that's really a balance when we're trying to change these behavioral patterns. But according to the procurement, obviously we need more transparency around data throughout the whole value chain, what's going on both the climate, the ecological and the social area according to sustainability, and how can we address that more directly, and what are the options of controlling that it's the truth we're being told. And we also need more standardization. That's what we hear all the time when we have good dialogue with the industry, who are in many ways they are one of the most important partners in this, and they are really positive and constructive in the dialogue. But of course, they're facing a very complex transition as well. So how do we standardize the demands we're making in procurement? How can we have a scoring model that have been very popular that we've been trying to use. We've made common Nordic criteria for sustainable packaging. So these big global companies don't need to adjust and address local, national demands and scoring templates. If we can standardize more, it's much easier to create the right transparency and common understanding and language around these things. So I think that could be a lever.
Great. Maybe I'll pose another question to Professor Mood. You've obviously been deeply involved in shaping the conversations around sustainable surgery. You obviously led with the example of gloves being one of the levers as a use case. Are there other transferable lessons from your work in surgery that could reduce our reliance on single-use plastics across the healthcare system?
Yeah, I'm going to be both positive and negative. The positive aspect. So I led a report called Green Surgery, which was an evidence-based review of how we can make surgical care greener. Now, let's be honest, the biggest thing we can do is have public health, so you don't need the healthcare in the first place. But nevertheless, let's talk about change on the ground amongst surgeons. what do we find is the evidence shows that healthcare workers are generally very supportive of the idea. Most healthcare workers don't want to harm our planet. They see every day the harms being done, particularly if it's materials, because materials are very visual and we respond to visual things in the same way we like putting it in the recycling because it's a visual thing, whereas that thing that was never used in the first place isn't so easy to conceptualize, but obviously is a far better thing. So there's a lot of enthusiasm and support for it. The difficulty again was actually implementing it. People come up against a big system that doesn't actually enable this. There are multiple actors, and unless they're all aligned, one person says no, or we can't do that, and that's it. And when you're a busy, certainly if you're a clinical person trying to lead this, if you're a busy clinician, you don't generally have time. And if you've got to drive, you try and push something, someone says no, you really have to fight hard, or you give up and carry on. So I think that's, again, what we need is a whole system to enable the change, not only from a top-down approach, but from those who are pushing from the bottom. So yes, we can support that because we've got structures in place to do that. So I've, for example, set up something called the Circular Economy Healthcare Alliance, which is a group of organisations, trusts, hospitals across the south of the UK, but we're open to other hospitals anywhere in the world so that we try to learn from each other and we transition towards reusable products. And all those institutions have committed. What that means in practice, we're still working out, but we've got institutional board leadership to say we will support that. And for us, our policy is going to become, we will reuse by default. If someone wants to say they won't reuse, actually, I'm going to ask them to make a business case, because making a business case usually stops people doing things. We'll say it's reuse by default unless you can justify otherwise.
Awesome. Thanks, Mood. Guy, there's a question from the Q&A box that might be more relevant to you, especially given your more hands-on, on-the-ground expertise here. So the question is, recycling plastics is possible, but segregation of materials is much harder. What is more beneficial to the planet in the long run? This seems to be a two-part question, but I'll let you jump in with your thoughts on that.
Yeah, I think the second part is where the value is, when you're saying which bit's more valuable to the planet. And I noticed from reading the report from Systemic and Eunomia that actually on the high ambition scenario, the most significant driver of greenhouse gas reductions was in the refuse, rethink, reduce section. So I think that answers the question. Recycling difficult to recycle things is potentially nice. It's a nut that will have to be cracked much later down the line on the route to decarbonisation. But efforts should be placed on refusing, rethinking, reducing, and I would include reuse within that bracket, because while gloves off is a great example of totally unnecessary use of an item. You know, once a patient does end up in a healthcare setting, they do need to be treated. So if that plastic item can be reusable, then that's all the better. And on that, on the point that Mood had just made about the different departments within complex organizations, I think that the experience that I have lived and SharpSmart have lived by implementing reusable sharps containers across lots of hospital systems very much speaks to exactly what Mood said, which is the early conversation might be that a very enthusiastic matron from the emergency department will say, I'd like to make that change and I will train my staff to make that change. I'm really, really keen for it. But the hoops that they've got to jump through are not inconsiderable, especially when this change needs to be made hospital-wide. And from a procurement standpoint, this change will have to replace what was one category manager who used to deal with single-use procurement. There was also a category manager who manages the waste management contract. These two categories don't necessarily talk to each other. So this ED matron, as well as probably having one of the busiest high stress jobs in the hospital, has to magically make these two procurement categories speak, and like Mood said, probably build a business case. We can quite quickly see this barrier is insurmountable at a individual clinician level. So yeah, things can make it work, such as scoring templates for product categories, like Maria suggested, or new frameworks which are for reusable products or solutions, and that's something that we've noticed from NHS supply chain. They were one of the first national procurement bodies within the NHS to come up with a specific framework for reusable containers in our case, which I think is brilliant, because a lot of the hard work is done up front so that you don't have to have that individual expertise within each hospital. So yeah, that's a little bit of commentary about how it can look in practice within a hospital.
Great, thank you, Guy. I'm just taking a quick look at time. Perhaps now's the right time to look a little bit into the future. So if we put ourselves, and Maria, I'll start with you, if we were to be today in 2030 or 2040, what does success look like for you? Like if you had to look back and say the industry did it or made it, or we made this one change that ultimately led to a positive outcome. Can you maybe talk to that?
Yeah. If we want a bigger positive outcome, then one change is not enough, because this is complex. I think the most important thing we can do is to change some of the incitement structures. And that is a wide term. But like Mood said, how can we make reuse the default? Right now, it's vice versa. And that matters to us in the logistics, in the practical way we have made a hospital work, especially newer hospitals. And it also it's embedded in the industry, because if they want to make a multiple use product, it's far more expensive for them and more complicated for them to get the approvals in order to export it and sell it. I mean, it should be the other way around. That is really, really expensive, and you need really to explain why you are making this catheter or whatever it is, scissor, whatever. Why are you producing it as a single-use item? That really should be the hard way to go, where right now it's the other way. So if we could flip that coin, I'm pretty sure that would support a transition towards a more circular consumption, not just within plastics, but within all product materials.
Thank you, Maria. Mood, over to you on the same question.
So yeah, I mean, I'm going to talk about the circularity as the single biggest driver, and you know, you talk about material substitution. If I'm honest, I don't think people are going to substitute materials until you've got a reusable product, because plastic is cheap. So if you're going to throw something away, you're going to make it out of plastic. So what does it look like? I think exactly echoing what Maria says, reuse is the default. Everything in the health system is reusable unless there are good reason why. And that may be actually we can't in any way make this product safe if it is reusable. There's very few products that are like that, but there may be certain things like cannulas that cannot be. What else is it? It is enabled not only in the financial structures, because we say we're always going to buy that. That is world policy. Maybe I'm ambitious, but also the health systems have in place structures to enable all of that. So for me, my view is we shouldn't be asking hospitals to bear the brunt of that. They shouldn't be asked that staff have to actually create the infrastructure to decontaminate, sterilize. We should just have that as a central facility where it is centrally funded that enables all of that change, because you can't put that burden on everybody else. And so we have a very economically efficient, carbon efficient system. And the other thing that's never spoken about is it's not just plastics, it's all the additives that are in plastics that people don't even know about. 200-300 additives added, aren't even reported, prevalent in healthcare, going into patients' bodies, and we have no idea of the harms that they're causing. So we just need to eliminate those.
And finally, Guy, I'll give you.
Yeah, all of the above I'd like to see by in 2030. And I think to maybe help paint the picture, what you'll see is you'll see thriving sterilization, decontamination, laundry facilities, which at least if you look in some of hospitals in the UK, those have been mothballed or shrunk or reduced in their capacity. So we'll see those things thriving, and I think that low carbon energy is going to make those possible. Obviously, the historic laundries and sterilization units were all gas powered. Yeah, that's I think in nuts and bolts what we might actually see. I hope.
Great. Well, thank you all for your comments. I guess a few key themes clearly stand out from this conversation. One, that circularity in healthcare isn't just about reducing plastics, it's about rethinking at a systems level to improve outcomes for patients, communities, and obviously for the planet. We heard some pointed references to making sure that reuse is the default to drive change. We've also discussed quite a bit about the need for a holistic collaboration, both top-down and bottom-up. So it's not just a top-down strategy that drives change, but also pushing for demand bottom-up, and both sets of actors that need to come together. We had Maria talk quite a bit about procurement policy standardizations as another level that could potentially drive change and drive positive outcomes. So as we close here, I'd encourage each of you to consider how Europe's unique momentum from the EU policy frameworks to national health system leadership can be harnessed in your own context. Whether that means aligning procurement with circularity principles, sharing learnings across borders, or piloting innovative models, Europe clearly has the opportunity to contribute lessons in leadership that can inspire progress globally. On behalf of Eunomia Systemic, Healthcare Without Harm, and Practice Green Health, thank you all so much for joining us today on this webinar, and a special thank you to each of our brilliant panelists for providing your valuable insights on the topic. Thanks again, and see you all on another webinar real soon.
Thank you.